Hello, my name is Dr. Roderick L. Roll, and today I'm going to talk to you about vaccines. If you were in the classroom, we will watch this short 5-minute video on the function of vaccines. Two artificial methods exist to make an individual immunized against a specific disease. And there's many diseases we'll talk about: polio, SARS-CoV, diphtheria, tetanus. So immunizing an individual will protect them from receiving that specific disease. And there's two ways that a person can be protected: active immunization versus passive immunization. In the picture below, we have a president receiving a vaccine. This is an active immunization, which is when you administer a vaccine so that the patient actively mounts a protective immune response. So what that lady is putting into his arm is maybe a modified version of the entity that will cause the disease. That entity is foreign to Joe Biden. His immune system is going to mount a process, and we'll talk about this, where T cells are going to stimulate B cells, and the B plasma cell is going to differentiate and turn into a clonal B cell that will then produce antibodies. And the antibodies that are produced are against that said entity that was injected into Joe Biden's arm. Then, if Joe Biden is exposed to the actual real entity, he has already millions of antibodies that have been primed for that specific disease. And they'll immediately attack it, and the individual should not get very sick, if sick at all. Here's another way that you can be protective. It is called passive immunization. This is when an individual acquires immunity through the transfer of antibodies formed by the immune response of another individual or an animal. So let's talk about Bob. Bob is the white character in the picture. So we're going to give Bob an injection of the tetanus toxoid. Bob will then build an immunity against that chemical. Then we can, once he builds the immunity, then we can take those antibodies from his blood and then give it to a person who is not immunized. So this is called passive immunization. October 2020, Donald Trump was infected with COVID. And during that time, he was not vaccinated, or he was not immunized. So he got passive immunization. They took antibodies from Bob or antibodies from a horse, and they injected it into Donald Trump's bloodstream. And now he had the antibodies that immediately destroyed SARS-CoV. So those are two methods to be immunized. Vaccinated individuals can protect those around them from getting the infection. This is called herd immunity. During COVID, on every TV station, they talked about herd immunity. They wanted to get a certain percentage of the population immunized, either being exposed to it where they built antibodies against it, or if they had the vaccine and built antibodies against it. So they wanted to get a specific number that is called the herd immunity. When, if we have, let's say, 85% of the population has been infected or have antibodies, then if a person from another country or from another state or from another county comes into your environment, it will most likely not make individuals sick because the majority of the individuals, 85%, have the antibodies. So what happens, this will protect the ones that are vulnerable, like the infants who might have not received any antibodies yet, or the very old. They might have a weakened immune system. So by having a certain population, a certain percentage of the population to be already protected, then you can protect the vulnerable. Not everyone in a community needs to be immune to prevent spread. If a high enough proportion of immune are immune, the majority will be protected from that pathogen. So the individual that is unhealthy, they are immunocompromised, they will be protected because the majority has already been immunized. The pathogen is less likely to be able to find the target, find the person that is susceptible so that it can enter and cause its action. So in the picture I have a low immunization rate, which is not protective. That is not herd immunity. So you cannot protect the herd unless you have the high immunization rate. What is that rate? It depends on the disease. So measles, you need to have 95% of the population protected in order to protect the 5% who do not have the vaccine, or the 5% that cannot get the vaccine because they're immunocompromised. Polio. The polio vaccine, we need 80% of the population to be immunized. In the table, the chart, I have others like rubella is 85%, SARS between 50 and 75, smallpox 80 to 85%. So the herd immunity, the threshold is different between different diseases. Now we will look at the different types of vaccines to give us active immunity. We have attenuated vaccines, we have inactivated vaccines, toxoid vaccines, combination vaccines, and vaccine using recombinant gene technology. We will first talk about attenuated. Attenuated live vaccines emerged in the 1950s with advances in cell culturing. Cell culturing is when you could take a hepatocyte, liver cells, and culture them in a petri dish or a horizontal flask. So first, the technology had to be invented. How can we cultivate cells that come from humans or cells that come from animals? Now we're going to take this entity and weaken it. So attenuated means weakened. So the attenuated pathogen is active, but it has the virulence has been reduced. They are weakened by repeated subculturing. So remember, virulence can be many things. It could be, for example, the slime layer that certain strands of Streptococcus produce. This slime layer protects it. It kind of camouflages it from being seen. That specific function gives it virulence. Some bacteria have proteins that it will produce to make it stick. Some bacteria have fimbriae that allow it to stick. All of these are virulence factors. It helps it make us sick. So when you attenuate, you weaken the pathogen. Maybe you eliminate one of those factors to allow it to stick or to be evasive or to hide once it's inside. Now, how do we make it weaker? You start off with cell culturing. So viruses are often attenuated by raising them in tissue culture, for which they aren't adapted to. They will then, over time, lose their ability to produce the disease. Now, this may take many passes through those horizontal flasks. You put some cells in that horizontal flask, you allow them to grow, and then you remove them and you put them into another flask. That's another pass. So the cells that we're going to talk about can be bacterial cells, but in this one specifically, it's a virus. So how do you make a virus weakened? You're going to raise it in tissue culture over and over and over again. And it will never be able to adapt to that environment. So if you keep changing the environment, it will eventually make that virus weak, which is called attenuated. The original 1954 measles virus strain was transformed to a weakened state by performing 10 years of serial passages between different tissue culture media. So they started off, they infected a human kidney cell with the virus. They put it in that horizontal flask. Then they removed it from there and put it into a fertilized chicken egg. Then they took it out and put it back in the human kidney cells. And they did this over and over for 10 years to develop a weakened strain of the virus that causes measles. And this occurred in 1954. Bacteria can be made avirulent by culturing under unusual conditions or through genetic manipulation. This image is genetic manipulation. You can see where they're going to take the gene out that causes virulence. So let's say the gene causes those triangles to form. And the triangle allows the bacteria to stick to your, let's say, blood vessel or the endocardium. Let's say we're talking about staph or strep that causes endocarditis. So this is where the bacteria is able to stick to the heart valve. So let's say it sticks because of that triangle. But now I can delete the gene that makes that triangle. Now if you look to the right, when that bacteria grows, it's harmless. It has been weakened because it no longer produces the triangle. It's still living, but it's not harmful now. A relative small dose of attenuated vaccine is administered to the patient, which replicates enough to stimulate a strong immune response. Attenuated vaccines can result in mild infections, but are not disease causing. We remove the triangle from that organism, now it cannot stick. But when we introduce it into the patient mounts an immune response to that bacteria, but the bacteria is harmless. So now you're going to produce antibodies for the other things that are on that previous slide where I showed you that bacteria. So this is why you only need a small dose, because when I introduce this vaccine, the bacteria can still replicate over time. So then your body is going to continue to produce antibodies against that bacteria. So a small dose is needed when it comes to these attenuated vaccines. Let's look at some problems with attenuated vaccines. Number one, attenuated microbes may retain enough virulence to cause disease, especially in immunosuppressed individuals. So remember, we're putting a weakened bacteria into the person, but it's not dead. So it may still cause the sickness. Number two, problem with attenuated vaccines. Pregnant women should not receive these live vaccines due to the risk of the modified pathogen crossing the placenta. Again, it is weakened, but the developing fetus is in its most vulnerable state. So you don't want that modified version that's weakened to now affect the embryo. Number three, problem with attenuated vaccines. Modified viruses may occasionally revert to their wild type, or they may mutate to a virulent form. So we're going to talk further about reverting back. So when you have one that's weakened, it could technically revert back to its original bad form. Here's an example of reversion. So the oral live polio vaccine reverted to a disease-causing form in 2000. A polio epidemic occurred in the Dominican Republic and Haiti, and since then the U.S. no longer uses this to immunize children. Here are some examples of live attenuated versions of vaccines. Measles is the one we'll talk about. So the MMR vaccine would specifically discuss measles, zoster, we have smallpox, we have chickenpox, yellow fever. So all of these are examples of live attenuated vaccines. They have been modified and they're used. Let's go further on the measles vaccine. It is against measles, the disease. It is modified, attenuated, but still live, and is administered subcutaneous. Is the measles even bad? I believe so. These are some of the symptoms from the measles: high fever, sore throat, tiredness, cough, runny nose, rash. Look at those children. Look at the rash. Red or bloodshot eyes, diarrhea, stomach pain, muscle aches, and headache. I don't think anyone should be exposed to that, especially if we can eradicate it. So the vaccine for measles is a 2-dose vaccine. The first dose is around 12 to 15 months, and the second dose is between 4 and 6 years old. One dose for the measles is 93% effective against the person acquiring measles. 2 doses of it is even better. Now it is 97% effective against the measles. So this is a 2-dose regimen to make the person immunized. It's a lot of negative media talking about vaccines in incorrect ways. So let's set some of the records straight. So getting those vaccines will protect you against the disease, but you may still have some side effects. They call it the adverse side effects. So these are some of the possible side effects: soreness, redness, or swelling where the vaccine was given, fever, mild rash, temporary pain, and stiffness. Let's look at the history of the measles. So 1960, we had roughly 500,000 cases of the measles. Then in 1963, that was when the first licensed vaccine was. Look after the 63 introduction at how the number of individuals receiving this disease dropped significantly. In 2000, elimination was declared. Currently in 2025, we do have a few cases. We have 1,168 cases, and that is because some of negative publicity from this unqualified, undignified idiot who put out some fraudulent papers in the late 90s claiming that the MMR vaccine caused autism. And because of that, the media took the story and sensationalized it. And now a lot of people, not a lot, some people are not getting the vaccine. This is why we've seen the numbers creep up over the couple of decades. So this is another view from the CDC website to show you that in 2000, it was just about eradicated. But now, look at 05, look at 2010, look at 2015. We start to see these spikes. We have a lot of negative publicity, people talking about it. We have these internet doctors that are now prescribing medicine and telling people not to get vaccines and not to give them to their kids to protect them from those debilitating symptoms that I just showed you on the previous slide. So now lately in 2025, look at how many individuals are actually getting the measles. So again, the overview of the vaccine regimen for individuals. If you have an infant, you would give 1 dose around 12 months and the second dose around year 4. That concludes the live attenuated discussion. And these are some examples: measles, mumps, rubella, that now is administered at 12 months and 4 years in the form of a injection called the MMR vaccine. The second one we'll discuss is the inactivated vaccine. They were discovered and introduced around the 19th century, and this is according to Western medicine. I have seen some data that suggests that the Asian and Africans were using this way before the 19th century. The inactivated vaccine can be separated into two types. We can take the whole pathogen and deactivate it, so it's dead. Or we can take a portion of the pathogen called a subunit. Common inactivation occurs through chemicals, heat, or radiation. One example of inactivation is with the hepatitis A vaccine. This virus is inactivated by using formalin, which is a variation of formaldehyde. Some people are like, I'm not going to inject formaldehyde into my arm. Well, it's minute concentrations of it, and it's perfectly safe. But it's used to alter, to destroy the virus so it will not make you sick. If this virus got into you, hepatitis A, it is going to cause vomiting, nausea, fatigue, fever, very high fever, and so on. So again, this chemical is used to alter and destroy this virus. So formaldehyde is commonly used to inactivate microbes. How? It cross-link their proteins and their nucleic acids. If you cross-link nucleic acids, then when your polymerase is trying to read from 3 to 5 and replicate from 5 to 3, it gets caught up in a bind, and it is not able to replicate. So this is how it destroys. During inactivation, the antigen responsible for stimulating protective immunity must not be altered. So whatever that you want to alter it from being able to replicate, but you still want fragments of it to exist and not be altered so that it can stimulate an immune response. And the immune response is when the T helper cell is going to help activate B cells to produce antibodies. Inactivated vaccines are safer than live vaccines since they cannot replicate or mutate to a virulent form. Previously, the attenuated ones are able to revert back. I use that term, revert. These cannot because they're dead. Therefore, immune compromised individuals can acquire these vaccines. So these vaccines will be the previous one, let's say not 100% of the population can take it because some people are immune suppressed. Whereas now these are safer. Now we can target a larger population with these dead inactivated vaccines. Some of y'all are still probably wondering about them injecting you with formaldehyde. So residual altering chemicals such as formaldehyde may remain in these vaccines after they've been used to create it. But the concentrations are so small it poses no risk. And if you're so worried about formaldehyde, in the pictures and the images, these are some other things you might pick up formaldehyde from. Smoking cigarettes, vaping, it has formaldehyde in it. Foods have formaldehyde in it. You just don't want a high dose of it. And again, these vaccines, you're not getting but a few doses of them. Inactivated vaccines must be administered in high dose since the killed pathogen cannot replicate. This requires multiple dosage since they're not replicating. High and dose increase the risk of allergies and may cause local inflammation. So the previous one, they're minute concentrations that are being injected into you because the bacteria is still living and it can still replicate. Those are the attenuated. These are dead, so you have to increase the amount that you're injecting into the person. So that's why I'm saying a high dosage. I'm not saying they're throwing gallons of formaldehyde into your bloodstream. They're just a higher dose than the previous. But these high doses do increase the risk of allergies. Antibody titers against inactivated antigen diminishes with time. Therefore, periodic booster shots may be required. So the attenuated, the organism is living and it lasts longer. So it's gonna give you a better response. You're gonna activate T cells that can remember that exposure. Whereas this one, it's not the same. These are dead, so the antibody count is going to diminish over time, and you're going to need a follow-up injection called a booster. Examples of inactivated vaccines are hepatitis A, polio, rabies, and pertussis. We're going to talk specifically about pertussis. Pertussis is caused by bacteria. That is the bacteria. The name of the disease it causes is whooping cough, and it is intramuscular injection. Some of you are asking, well, what is whooping cough? These are the symptoms: a slight fever, a mild or occasional coughing, runny nose, and a pause in breathing for babies. So mothers especially fear the whooping cough for their babies. Therefore, they most of the time get vaccinated. They vaccinate these babies. The vaccination for whooping cough is a 5-shot regimen. So previously, with the attenuated, we only gave 2 doses. With this one, we're going to give 5. So 3 shots are going to occur when they're very young, 2 months, 4 months, and 6 months. 1 shot between 15 to 18 months. Then 1 more shot 4 years to 6 years old. This injection is a combination of other disease vaccines as well, and it's called DTaP. We're only talking about the P for the DTaP, which stands for pertussis. Yes, the actual vaccine has some adverse reactions: pain, redness, or swelling in about 20 to 40% of the patients, a temperature of 101 in about 3 to 5% of the patients. This is the history of cases of pertussis. 1922, about 100,000 individuals had it, and it increased. Then the first vaccine around 1940, then you see the decline, steady decline of individuals who are getting pertussis. Look at the 1990s, still relatively low. Again, 2000, that doctor, fake doctor, that produced the fraudulent papers that had them retracted, lost his medical license, all that stuff happened to him because he's a fraud. But remember, that's why you see these spikes of cases of pertussis. People are not getting vaccinated. So they also have it enlarged a little bit better so you can see. And more recently, around 2023, about 7,000 cases of pertussis. This slide here from the CDC breaks it up even further and looks at, remember, the vulnerable or the babies. They might have paused breathing. That's not a good thing. So look at the green line. You have more cases of babies getting whooping cough. What can you do? Get vaccinated. This is the vaccine regimen. So D for diphtheria, tetanus, pertussis, DTaP. You'll get one vaccine at 2 months, the second one 4 months, the third one at 6 months, the fourth one 15 months, and the fifth one about 4 years old. So we're done talking about inactivated. Inactivated, somehow modified, where it's dead. But you need to get a higher dose. We'll move on to the next one. Some bacteria produce toxins like Clostridium. It produces a toxin and you get sick from the toxin. So we have the diphtheria bacteria we just mentioned. It produces a toxin called the diphtheria toxin. The second picture is the Clostridium that's producing the tetanus toxin. So this brings us to the next category, toxoid vaccines. They're chemically inactivated antigenic components of the original toxin. So the toxin that causes lockjaw, they're going to take that toxin, tetanus toxin, and chemically modify it. And that is going to be injected into your arm. That's a toxoid vaccine. The most notable toxoid vaccines are diphtheria and tetanus. We will specifically talk about diphtheria. Some of you are wondering, well, what are the symptoms? I might gamble and not vaccinate my kid. Everybody doesn't get it. You're only talking about 500,000 people might get it, or 1,100 people. But do you want your kid to have these symptoms? Sore throat, swollen glands in the neck, barking cough, racing heart, wheezing, difficult breathing, chills, and fever. This image of this little boy was posted on the Mayo Clinic. He looks very miserable to me. Probably should have been vaccinated. This is the bacteria that caused that boy to have that swollen neck. Is aerobic gram-positive bacillus bacteria. This bacteria is unique because it has been transformed. It was infected by a virus. So a virus that attacks bacteria is called a bacteriophage. So bacteriophage infected this corneum bacterium and transformed it into the entity that causes diphtheria. Here's the history of it with the cases. 1920s, about 150,000 to 200,000 individuals would get this annually. By 1960, it's eradicated, gone. 2018, what was happening in 2018? Right before COVID. A lot of rhetoric, a lot of politicians talking about MMR vaccine causing autism. So you had a few people not get vaccinated. So about 14 cases were observed in 2018 versus 2019, no reported cases. So I hope it stays at 0. Another one we'll briefly talk about is lockjaw. This is, you've heard of stepping on a rusty nail, but it's other ways to get tetanus, a dog bite, a crushed limb. What happens is, we'll go over this in micro, where the antagonist and the agonist of muscles both contract simultaneously. Person might have difficulty breathing. The diaphragm can't contract correctly. The person could die from this. Those are the symptoms. Let's look at the number of cases. So 1950, about 500 individuals. That's it, 500. So I understand the debate when individuals say, well, we don't need the vaccine. It's not that many people that acquire this disease. I agree. But if you acquire it, you might die. So it's a gamble. So 1950, about 500. 1910, there's been, 2010, since 2010, there has been less than 40 reported cases per year. So it's the number is very, very small. Now, the individuals that are gambling, saying, look, it's only a few people to get it, I would say this. There's only a few people that get it because of herd immunity. Because there's so many individuals out there that have the DTaP vaccine, it protects those people that refuse to get vaccinated. It protects those individuals that can't get vaccinated because they are immunocompromised. It protects those individuals that come from other countries that don't have the vaccine regimen that we have, a vaccine schedule. It protects them. I showed this slide previously, DTaP. I showed this slide previously, the actual vaccine schedule for DTaP. I'm now concluding the discussion on the toxoid vaccine. The next type of vaccine is combination vaccines. You will have combined antigens from several different types. You have an attenuated in there. You might have an inactivated vaccine in there, and you might have a toxoid all together. And these are some examples, the MMR vaccine and the DTaP. They're combination vaccines. The one we'll conclude with is recombinant gene technology vaccines. Is a newer technology that will produce cheaper, quicker, and larger quantities of very pure antigens that will be the vaccine. Virulent gene is deleted to create an attenuated pathogen that is used as a vaccine. This type cannot revert to the virulent form. This produces a vaccine. That is one example of using recombinant gene technology. I'm going to delete that gene that makes it be able to revert back. The gene coding for the antigen is isolated and inserted into a bacterium. This bacterium, using its enzymes, will then produce the product from that gene. That product is mRNA, which then turns into protein. That protein is the vaccine. Now you introduce that vaccine into a patient. Their body immediately identifies it as foreign. Their body will then develop antibodies to attack the protein. Here's a different type. Insert gene coding for the specific antigen into a cell. Now the cell is going to express the protein, but notice this is a little different. The other one, the cell released the protein, and we use the protein that was produced as the vaccine. This one, the cell expresses the protein on its cell surface. The entire recombinant entity is going to be used as the vaccine, not just the protein, the actual cell. So it's a little different than the previous one. This slide sums up what I just said. We have a viral vector that has been modified, and now it expresses that protein that we need it to express. Here's another type. Injecting plasmid containing gene of interest into the patient, or the ability to produce the product of interest into the patient. So either you put the plasmid into the patient, the plasmid has a gene, the gene produced a protein. Or I can introduce the actual mRNA, and the mRNA is then going to produce the protein. Either way, the patient cell will produce that protein. So that would be the vaccine. To further illustrate that one, think about that mRNA vaccine that we got from Moderna. That's what it did, was they introduced the mRNA that is going to make the protein that is going to be the vaccine. This last slide summarizes what I just discussed in about a 5-minute video. If we're in class, we will watch it.